Hello, everyone. Welcome. Thank you for joining us again today. Shaun Brewster, Bodine Ledden here with you as per usual. Bo, today's episode is kind of in response to some really good conversations we've had with students and listeners of this podcast in recent times about some recent episodes we've been doing that have been challenging some long-held misbeliefs, misconceptions, misrepresentations about manual therapy and the things that have been claimed that it does over many, many years. And if you've been tuning in and listening to this for a while, you'll know that there's been some potentially, I guess, contentious discussions that we've had around some of these claims, like things that can and can't be released, and the effects on the body that people claim, like does a massage, for example, improve or reduce the risk of injury? Can we release an SIJ? Can we release all these sort of things, like the language we use? So, Bo, today thought we were going to have a chat about some of the positives of manual therapy. Now, anyone that knows us, Bo, will know that we are devout supporters of manual therapy. We love it. Like we use it, we teach it, we live this stuff. And so we don't want to get anyone confused. We are lovers of manual therapy. So let's talk about all the things that it can do with our patients.
Yeah, that's right. And everything has its place, but it's knowing what that place is. If we're saying that we can treat and fix and heal everything with manual therapy, well, that would just be not true. And we know that manual therapy can serve as a great benefit for patients. They want it, they like it, and we can use it to modulate people's pain. We can use it as a part of their rehabilitation journey. But it's just, when things are claimed that aren't actually true, that's the problem with manual therapy when in any modality for that matter, that where we can run into some trouble. So it's just understanding what it is good for and what we can use it for and where it fits in the overall puzzle in managing and treating people with pain. So that's super important.
Yeah, and you're right. Look, it does. We know that people love it. They enjoy it. It makes them feel better. We get results. We can see results clinically with it. So there's no disputing that at all. We had a really good podcast last night with James Schomburg, and he was talking about some of these ideas. And he mentioned something that I thought was a really, really important point with this. So manual therapy definitely does reduce people's symptoms of pain, of restricted movement. They feel better as a result of having a massage, joint mobilization, needling, cupping, whatever it might be, right? You can't dispute that people have the treatment and feel better. And often the effects that they have will last for a day, 2 days, 3 days, 4 days, sometimes longer. But it's typically that 2, 3, 4 days. And then if the thing that has been causing their symptoms to occur in the first place is still present, well, typically those symptoms will come back. And because of that, manual therapy has sort of copped a bit of flack about, oh, well, it's only temporarily changing symptoms. And James made this good point. Name something else that gives you pain relief for 3 or 4 days. Imagine if there was a pill, some kind of medication that you could take that would reduce your pain for 3 or 4 days. Imagine if there was a single exercise that you could do that would manage your pain, would reduce your pain experience or improve your function for 3 or 4 days. There's nothing. And so, yes, it is temporary. It does have a limited time frame in its effect, but when we compare it to the alternatives, it's actually a really, really good option as far as improving people's quality of life.
Yeah, and when we look at, the research, systematic reviews and meta-analysis looking at the effects of manual therapy, well, it can certainly be beneficial, and it's even better in combination with other modalities. And so when we look at anything, I think if we're consistent with it and progressive, then that's really important. It would be like starting a new diet and doing that for 3 days and expecting to get really good benefits from it. So use manual therapy where it fits to modulate pain, use it to decrease people's fear of movement, use it to provide confidence in movement, use it to challenge beliefs about structure. Because if we can perform some manual therapy and people perceive that they've got this structural problem that can't be fixed with anything other than surgery or injections, and if you can reduce someone's pain in that short period of time, what does that say about structure? What does that say about the experience and the perception of pain? Like, you see this all the time. And for example, with Jeremy Lewis's shoulder symptom modification program, if someone's got sort of this perception that there is a bone that's stopping their humeral head from moving, and that being the acromion, you know, and if we can mobilize that joint, or put it into a slightly different position and then allow them to move, and they go, oh, I can do that. And you say, well, what does that tell you about the structure? What does that tell you about the symptoms? So what we're actually doing is we're providing a different input. We're not doing anything outside of that, but providing a different input. So the perception of that movement is different. We can challenge their beliefs. We can challenge their behaviors, or that can influence their behavior. And then we can start to promote more positive changes that's associated with that. So absolutely, manual therapy can have some fantastic benefits. But again, we sort of peel back those layers and understand, what are we actually doing? We're not lengthening the tissue. We're not breaking up tissues. We're not, putting things back into place or anything like that. We're not using it to prevent injury or anything like that. We're using it to modulate pain. We're using it to reduce inhibitions to movement and exercise, reduce fear, reduce apprehension, guarding, and just desensitize the patient's nervous system in general.
Yeah, good one. Look, but I've had a couple of interesting conversations with listeners of the podcast and readers of our newsletters and things recently, and a few people I've spoken to have been kind of really disheartened, I think is probably the best way to put it, about this new understanding that they're developing through listening to our stuff and reading our stuff, about it not being a structural change. And I think for a long time, I know I was taught, you probably were as well, that what we do with our hands on a hamstring or a QL or whatever the muscle or tissue might be physiologically changes the state of that tissue, in that it'll make it longer. Let's strip the calf out. Let's strip the hamstrings, make them longer. And then when you tell somebody, well, we're not actually making it longer, it does rock their world a little bit, of course. Like it's like a change in religion almost. Like you have to believe something new that you would believe for so long. And it's really hard to come to terms with that. And I completely empathize with anybody who's having to, change the way they think about things. But when we think about it, it's kind of empowering, because no longer do we have to rely on these structural changes or beliefs in about changing length of something. Now we can look at it and go, well, we're changing the way something feels. And if you just say it like that without giving it any more depth, it can be very easy to take it as, oh, I'm just making you feel better. I'm not doing anything. You may as well just go and have a nice fluffy massage at a spa if you've got back pain, and you'll still feel better. And therefore, how is it any better than what we're doing in a clinical application? Well, I'd say, well, you can be quite a bit more targeted. You can be more specific, and you can get more strategic with your approaches clinically. Um, and while we might be just making the person feel better, but it's not just feel nicer. It's actually be able to feel better, be able to use your sensory organs more effectively, and use them to report information back to our central nervous system more effectively, so that central nervous system, the control center, can produce better output. And it goes well beyond just making somebody feel nice. It's about improving their communication, their internal communication system. And so while we're not necessarily changing the length of a muscle, what we might be doing is improving that muscle's ability to communicate with the central nervous system, so the central nervous system can then modulate muscle tone, which then, by effect, kind of allows the muscle to lengthen more than it otherwise would have. If you have better neuromuscular control, maybe you'll be able to move through greater ranges of motion. Maybe you'll be able to produce more force. Maybe you'll be able to move more efficiently. And that's about feeling better, being able to feel better through your sensory nervous system, and better motor control as a result. And so let's think about this change in religion, this change in thought process, as an empowering thing. Yes. So no, we don't necessarily change the structure, but we change the function. And ultimately, that's why people come to us. They have a dysfunction. They have a pain problem. They have a movement problem. Primarily the things people will come with. So if we can improve their function through working with their sensory and motor nervous systems, well, then that's ultimately the goal. If all we did was change the length of tissue, for example, and we all know that manual therapy for the most part will last a few days and it's not permanent, well, then how is that any more empowering? Because if it just goes back to the way it was, well, then we just have to go back and do the same thing again, which is essentially what we're saying we have to do. It's just a different explanation about how we get there, and understanding that it is an exchange process between our peripheral and our central nervous system, Well, then once we understand that, we can be more targeted, we can be more specific, and we can get really empowering results with our patients.
Yeah, and we also think about it like the perception of danger or the perception of threat. So someone who's in pain will have a heightened perception of potential tissue injury or potential danger based on their previous experience and expectation. And so this could, for example, you could test someone straight leg raise, and they might have some stretch based pain. All right. And then you could rub that area, you could stretch that area, you could mobilize their hip, whatever that may be. And you might see a significant increase in range of motion almost immediately. So, what did you do? Did you really change what's happening to the tissue, or did you change the perception of threat or danger? All right. And so the brain is really good at this interpreting information to protect us from danger. And so someone that's had a bad experience or they've had a painful experience before, well, the brain is not just waiting for passive input to tell it that there's something going on. It's going to be sort of one step ahead, trying to protect and guard that area. In the fear of injury. And so when we talk about these other factors that influence a pain experience, fear, anxiety, worry, threat, these kinesiophobia, right? There's a number of different things that is going on there. And if we can provide a positive input to an area, whether that be just massage, myofascial release, mobilization, needling, whatever that may be, that input can create changes in the central nervous system. And so we see that with chronic pain presentations where long-term nociceptive input, noxious input can lead to nociplastic changes, so these structural and functional changes in the nervous system that influence our behavior and the emotional aspects that go with that. Okay, and so with manual therapy, maybe it's not so much the structure anymore. It's about providing that different input, reassuring the patient, showing their body, showing them that it's actually okay, it's safe to move, it's not a threatening movement or stimulus, and because that can be a learned behavior. So there are significant benefits that we can see with manual therapy. It's just shifting the focus. And just to give you another example, like if someone has pain in their back, they're going to feel like it needs to be pressed on. So you can go and press on that area and go, tell me how that feels. So you're having this constant conversation with your patient. Yeah. Oh, that's sensitive there. Okay. Is that manageable? Great. Let's just stay here for a little bit. Let me know when it gets less sensitive. And then you might go back and reassess with whether that be with movement or palpation. Is that any better? All right, let's try this spot. And then so you're having that sort of I guess constant communication and that shared relationship with your patient to see if we can modulate their experience of pain, which then in turn may improve their range of movement and their confidence with movement.
Yeah, 100%. And even beyond this, I think another thing to consider is patients' expectations about change too. Like a lot of the time, if you are a practitioner who is perpetuating this idea of I will make some changes to your body and that will make you better, like I will put that joint back in, I will adjust something, I will, release something, lengthen something, and the patient's going to feel better, right? They will feel better almost every time when you do something that feels nice. And then they will invariably go back to having the same symptoms at some point if nothing else changes, right? If you just do the treatment and then no other inputs, nothing else changes, they sort of end up back there. And you can see how a lot of patients would then get very frustrated with that practitioner. It's like, well, you kind of half fixed me, and now here I am again. And is it a problem with their expectations, or is it a problem with the messaging? Because if we set the expectation that like I'm going to release your anterior compartment and your compartment syndrome is going to be better. How does that work? Well, I'm going to break up the connective tissue. And we know that that's rubbish. You can't do that to a compartment of a lower leg. But if you perpetuate that kind of story, patient walks out going, wow, they released it. It's all good. I go back to my running. My pain's back. Maybe they actually don't know what they're talking about. Maybe they're not as good as I thought they were, or as much as they might have explained themselves to be. And so you then kind of shoot yourself in the foot by starting with this story. So if you start then with going, look, you've got anterior compartment syndrome, I can do some manual therapy. It's going to reduce some symptoms, but here's the things that need to change to make sure this doesn't come back. And it's a two-way street. I'm going to do my bit, you're going to do your bit. And if we both do our bits and you head in the right direction, then what you should see is progressive improvement over time until the problem goes away. And that's a much better expectation to set from the beginning. That's what I mean by let's not be disempowered by the claims that we might have once made about manual therapy and what we can do to tissue. Let's be empowered by the opportunities that are now created by this new understanding, this better understanding about how we can interface with the physiology, get it to change progressively over time, have the patient participate in that change. And it's the physiology, not the anatomy, that changes. It's how the parts of the machine work together. It's not the parts themselves being changed. And so I think this is a real opportunity to both empower our patients, give them better expectations, and then through that, we set them up for success, not disappointment.
Yeah, that's a great example. And that sort of narrative also of saying to our patient that it's because it's short and tight and it needs to be lengthened is just as unhelpful as saying that a joint is out of place and it needs to be put back into place. Be careful of movement because the joint will go out, or be careful of movement because your muscle will tighten up again and it will need to be lengthened. And that's just not true, right? It sort of also goes back to that old outdated upper and lower cross syndrome. Remember that, where it was sort of like, oh, well, your pecs are short and tight, which means your muscles at the back or your rhomboids are long and weak. And that's why you've got shoulder pain. And you have to lengthen out the short muscles and strengthen the long muscles. And while that might make sense in a very biomechanical framework, it just doesn't make sense when we consider the complexities of pain. Furthermore, if we think about nociplastic pain, all right, and we're looking at everything through a structural framework or a biomechanical framework, well, then that is also very unhelpful. So with chronic pain, when we know there are structural and functional changes in the nervous system and all sorts of different factors that are going on and contributing, if we're just then going back to, well, we've got to change this structure for your pain to go away, then that can be really unhelpful when that fails.
So, yeah. And it really is just about setting realistic expectations, using language that is sensible, right? It's this language that people can identify with, they can connect with. It's not making claims, is it? We're not making claims about changes we're making. We're making claims about the opportunity for something different. That's all it is. And like you said before, pain is such a complex thing. And if pain wasn't that complex, if it was just about the structure, then somebody who comes to you with arthritic pain in their knees and you give them a nice massage should not feel any better. But you can do a whole bunch of different manual therapy techniques to somebody with arthritic knees or ankles or hips or whatever, and they will feel better. There's no change in the arthritis. You can't alter that degenerated joint surface, and lining of bones. And like you're not going to alter that with any kind of manual therapy you do. But we know that pain can dramatically be reduced when somebody has a preferred neurological input. When they have structural change going on in the tissue, there's potentially the source of their pain. And if it was that simple, then we'd be healing all sorts of things. We just changed temporarily the symptoms for the person to create an opportunity for more movement, for better movement, for other opportunities, for reduced fear, reduced apprehension, improved confidence. And then we can get them to do the thing that they need to do that will actually make the biggest change long term. And I think the biggest pitfall and potential danger in being a manual therapist is telling these stories to patients that aren't true and perpetuating the wrong beliefs and expectations, but also creating this system whereby patients need to come back and see us forever, because they believe that the only thing that's going to manage their symptoms is the thing that we do with our hands or the tools that we use or the needles that we use or whatever it might be. When those are you go and open a mechanics workshop, there's 1,000 tools, right? They can all kind of interact with the engine, but what's the right tool on the right day? Well, that'll be the thing that starts the change, but then you kind of you work with the whole person. You need to work with the whole individual and all the things that impact their pain experience. And the tools are less important than our understanding of the patient. that are less important than the understanding of the complexity of that patient's presentation. And there are 1,000 ways to skin that cat.
Yeah, and you look at that even from, that this sort of integrated model of assessment, treatment, education. A patient comes in and firstly you're going to ask their story. What are you here for? What can I help you with? Um, how is this affecting your life? All of these things, and you might have a look at the way they move and say, tell me about that movement. What is it that's stopping you from going further, or what is it that's stopping you being able to do this? And often it will be something like pain, stiffness. They could be a bit fearful or a bit worried. And so we use that to see, all right, well, if I could modulate your perception of pain and your perception of tightness or limitation, or give you more confidence, which could influence your fear of that movement or your worry of it getting worse, let's work with that. And so when you go and press on an area, you say, all right, well, let's see if this can decrease your pain. Let's have another look. Now tell me how that's feeling. All right. So we're influencing their perception of pain. We're using manual therapy to modulate it and then getting them to repeat those movements and repeat them again so they can get more comfortable with it. I think the thing is, it's easy to go in this down this structural narrative and explaining things about alignment, posture, structure, pathology. Um, it's harder to go to view this from more of a biopsychosocial viewpoint. Um, but if we can just change our language that little bit and use, instead of focusing on the pain and focus on the optimism or the positivity or the things that they can do, that might be a better way forward. And there's some really good research about changing attentional focus, and there's an abundance of research around language and how that can influence a patient's experience and their expectations. So yeah, I guess focusing on structure and that's the problem that's stopping them from doing the things that they want to do, as opposed to looking forward at, look, we can modulate that, we can decrease your sensitivity, but let's focus on things that you can do and see if we can start to progress that a little bit further.
Yeah, good one. Look, I've again had some conversations recently with people who have been feeling a little disempowered by this change in paradigm, for want a better term. And I think it's partly due to the fact that there's the language they're using with the patients to explain a diagnosis or a presentation. It's still in the old model, yet they're trying to talk then in the new model. And that's where they're getting stuck in this kind of rift in the middle. So they might be, you have a patient coming, use your example before of an impingement presentation in the shoulder. You think, okay, well, you're getting that pain because as you lift up the tendon of your supraspinatus is getting compressed against this bone here. And that's why you're getting, and then their brain goes, oh, hang on a second, let's not talk structural, let's talk about functional. So you've given the patient that explanation. The patient now believes there's a bone squashing soft tissue, causing compression, causing pain. And then you go and say something like, okay, so all we want to do is like just improve some function. We want to get your range of motion. Once you get moving better, you'll start to feel better and it'll go away. But now you've given them two completely separate stories and they don't connect. And so if you're feeling stuck as a practitioner, if you're feeling stuck in this idea of an old model of thinking and a new model of thinking, you can't sit on two toilets at the same time. I don't know, I think there's a saying that goes something like that, right? You can't, you got to have, can only sit on one at a time. So if you take an idea and go, well, I'm going to do all of one or all of the other, you can't do half, right? So if you say to the patient something structural and then talking functional, you'll only confuse them and you'll only frustrate yourself. So you've got to come back and say, right, you've got this pain in your shoulder. Okay, when does it hurt? It hurts typically after I've been to the gym and when I've been sleeping with my arm like that. Okay. And so there's times that it doesn't hurt. Right. Okay. So that tells us that there's structurally probably nothing wrong. Functionally, you've got some irritation, some sensitivity. And I think switching the word pain for sensitivity is a nice place to start because it gives you a different framework to work with. As a patient, you're either in pain or you're not in pain. Sensitivity is a continuum. It's like a dial. Sometimes it turns up, sometimes it turns down. And I think that's a nicer place to start with your patients. So the sensitivity of your shoulder is kind of wound up to about 9 out of 10 at the moment. Because it's not like that all the time, we know that there's nothing broken, there's nothing torn. Otherwise, it'd be it'd be killing you all the time, right? In which case we might need further investigation. But for now, let's work on decreasing your sensitivity. We're going to turn that volume knob down so that you can get more time with less pain. And when you have more time with less pain, you move better, we can get you stronger, we'll get you back to your normal function. It de-threatens the whole situation. It moves you away from having to change the position of a bone or change the position of soft tissue so that there's no longer, compression occurring. And then you can start using that language more consistently and take your patient with you rather than leaving them back there while you're trying to go in a different direction. And of course, this takes practice, right? Especially if you're not used to it. And so trying to listen to yourself speak to a patient, listen to yourself speak to anybody about pain. What are the words you're using? What could be an alternative way to say the same thing that's less threatening, less structure focused, and more about optimism and opportunity and potential for change? And I think that can be a nice place to start because it can be difficult to know where to begin.
Yeah, and people don't need to move perfectly with perfect form or anything like that. If someone's doing something, can you reach over your head? Can you squat down? Great, let's start with that. Let's do a few more of those. Let's get you a bit more comfortable with it. Don't worry about your foot position. Don't worry about your back position. It's all good. Just relax and do it. Um, that over focus on specific movements and biomechanics and structure, it can, not be helpful. When we even look at the context of pain, and this just reminds me of a great study by Lorimer Moseley, actually, and it's how important context is in perception. And so what they did was they had a minus 20-degree probe, and they would apply this stimulus to the subjects under a number of different variable conditions. And they used either a red light or a blue light. And the red light would sort of increase the perception of tissue damage, whereas the blue would not so much. They also used the lighting system as a warning. So it was either applied simultaneously or 2 seconds before. They also had the participants either look towards the stimulus or look away from the stimulus. And they had a number of different visual analog scores for each of these. And so it was consistently reported to be more intense. And in fact, the perception of hot feeling when it was a very cold stimulus, a perception of hot feeling with the red light, it was worse when there was a warning, and it was worse when they looked towards the stimulus. And so you think, well, what's that mean? Well, if we are directing our focus and our attention towards a painful structure, warning people about pain or the potential for tissue damage or danger or nociception, that can increase their perception of threat. Now, because this is all an influence of the brain, and the brain will perceive these things and make sense of this type of stimulus, all right, because it is aiming to protect us from the external environment, all right. And so I think that's really interesting to consider. The way that we say things, the way that we do things, is that threatening, or is that less threatening when we consider manual therapy application, movement, language, and looking forward to the future. So yeah, I think that's a really interesting study. There's many more just like that as
Mm.
well.
That's a great one. And you made a good point there about your brain wants to make sense of things. Our brains are meaning making machines as well. They want to make sense of it, but they also want to have a meaning assigned to something. And so, when something hurts, your brain will kind of go decide for you what that means for you. It means that something's out of place. It means that something's short and tight. It means something's broken or torn or whatever it might be. You will create meaning around it. And so our job as health practitioners a lot of the time is to provide more effective, appropriate meaning for our patients. So the education part of it is probably more important than we might give it credit. I'll give you a very quick personal story. So, Bo, you know this. I went and saw a sleep doctor recently because I, for the longest time, have no problem getting to sleep. My wife will be upset with me about how fast I get to sleep. In fact, like I can lay down and I'm out, no problem at all. This is one of the skills that you get as you get a bit older. You can just go to sleep anywhere, anytime. But I tend to wake up many hours before I need to. And so I lay in bed thinking, oh no, I'm going to be tired for the day now. And so I thought maybe there's some things I could do, right? So my brain's assigning meaning to this. There might be a chemical thing going on. There might be some kind of circadian rhythm issue that I need to have adjusted, for a better term. I'll see a specialist. So I spoke to a sleep doctor and they asked me, what are my hours of sleep like? And I told them, and they said, well, actually, you're within normal limits. The range of hours that you're sleeping are probably about average. You could probably do with an hour or two more, but you're certainly not in a deficit of sleep. And so, based on what you're telling me, you're functioning reasonably well. There'll be times when you could sleep better, but on the whole, it's probably about right. And there was no more consultation required at that point because I now had a new meaning. And ever since then, funny thing, I've been sleeping longer because I'm no longer worried about my ability to sleep. And so I will sleep for more hours because I'm not thinking about what's actually wrong. I'm thinking about the fact that it's all fine. And if I could just relax a little bit with it, maybe I'll get a bit more sleep. And that's what's been happening. And so the power of our language is so important. Sometimes patients, sometimes we just need reassurance that nothing's wrong, that we can just continue to move forward. We don't have to feel stuck there. Then there are situations, of course, when there might be something structurally changed. Maybe, for example, there's an osteophyte growth, like something's grown on a bone that wasn't there before. And over time, that thing may cause encroachment on a nerve or a soft tissue or something. And yes, there's a structural source to somebody's pain. That is also possible, right? And in some cases, that might be a surgical intervention required. Some. But our biggest mistake is we assume that everything structural results in a structural change or requires a structural change to move away from that dysfunction or that pain. Not always the case because we see this was a classic thing with foot pain, plantar fasciopathy. We used to see lots and lots of surgeries for heel spurs until we realized that actually, if you scan a whole bunch of feet, heaps of people have got heel spurs. Not all of them have pain. And so why would you go in and cut someone's foot open and shave a bit of bone off when it's not actually the source of their pain? Maybe there's other things at play, like your point before, multifactorial. So there are scenarios, there are situations where there may be some structural something going on, which might require more than just some positive language. But there's also a lot of situations where there's a structural thing going on, and language is all that's required. So how do we know? Do we jump straight to the imaging? Do we jump straight to a surgical referral? Or do we try this positive reinforcement? We try this symptom modification. We see if we get the first line intervention. We see if we can get them some improvement in function. And how long does that last for? Is it manageable? Are there other things we can use to contribute to it? It's not working. Okay, then it's referral, right? That's when you go to somebody else because it's not what we're saying here about all the magic things that manual therapy can do for pain and particularly chronic pain. It's not the same for every single patient, but we've got to stop assuming that one size fits all because it's just not the case.
Yeah, that's exactly right. And that's the thing where everything has its place. And as you said, we can't use one thing for everything. So everything has its place. There will be places for surgery. There will be places for injections, pharmaceutical drugs, manual therapy. But I also think it's important to also understand, well, how specific do we need to be when we look at nociceptive pain versus nociplastic versus neuropathic pain? There's sometimes that we may need to be more or less specific, but at the end of the day, we come back to what are we really trying to achieve? We're trying to modulate the nervous system, modulate the patient's perception of pain, and start to integrate movement and exercise in combination with education that can have significant influences on all of the psychological impacts that can be associated with pain.
100%. Look, I'm hoping that this episode has been empowering for practitioners out there because I know our intention is to do that, of course, but sometimes when you're truth telling and when you're sharing ideas that maybe fly in the face of older people feeling a little bit feeling less empowered. And someone said to me the other day, like, what's the point then if all we're doing in clinic is no different or no better than, a good sleep, good nutrition, good exercise, then what are we charging people money for? Well, I think I said that at the start. You can't have a good enough sleep, good enough exercise, or good enough nutrition that would immediately, in the space of minutes, change somebody's pain for 3 or 4 days. Like there's nothing we can do in our general health that will give you an immediate reduction in pain when required at the drop of a hat. But if we do balance our lives and our bodies by having good sleep, good nutrition, good exercise, good habits, good beliefs, good all of those sort of things, then the need for manual therapy is reduced. Well, it should be. The need for any kind of healthcare intervention is reduced, as it should be, because your body works more efficiently the way it's designed to. And so manual therapy, like you said before, has its place. It is super powerful at modulating symptoms. It is super powerful at creating opportunity for the person to feel better, move better, have more confidence, and then get to the next step. And so I don't think anybody should be sort of challenging or questioning their place in the world as a manual therapist, because that thing that we provide to people is super valuable and so empowering and so life altering in the change in quality of life it can produce for people. And that's not something to be taken lightly.
Yeah, I mean, I use manual therapy in almost every session as a component. And so I think that's really beneficial. But I think practitioners out there, any trained health practitioner would rarely ever use one modality in isolation. And, when you're consulting with a patient, educating them, getting them moving, applying manual therapy, whatever that may be, well, it's probably the whole contextual effects of that as well. The fact that you're coaching them, building that therapeutic alliance, using your assessment, ruling out serious pathology, de-threatening that pain presentation is really important. That all can have effects on a patient's pain experience. So it would be almost ignorant to say that everything that you're doing is based on the structure and everything that you do with your hands, because there's so much more to that in a consultation as opposed to just pressing on an area like that plays a part of it. But yeah, absolutely, manual therapy can be fantastic, but it's not the only thing that you do in clinical practice as a manual therapist or as a clinician in general.
Really good point. Someone was saying the other day, like this was a massage therapist talking to me about it, and they're saying, well, I just do massage. I don't know, like that word just when you put it in front of anything, but I just do massage. So that really limits me as a massage therapist, because I've only got so many options. Like you guys talk about all these other modalities and the pain science and the language you use. Well, I challenge you to think of as a massage therapist, think of any consultation you've had with a patient where there hasn't been some form of conversation you've had that has helped the person's mind be at ease about something. Like you've got back pain. Yep. Here's some things that you could try at home, or that must be frustrating. I give you some empathy as part of that consult. These are all things that can help to modify somebody's experience. And so as a massage therapist, as a chiropractor, as an osteopath, exercise physiologist, doesn't matter, take your primary skill set and think about the things that exist on the periphery, and think about how sometimes you can maybe expand on those things. Maybe you can spend a bit more time just understanding the patient's presentation and offering some reassurance. Maybe you can, if you are an exercise focused therapist, and you do a little bit of manual therapy, maybe you can say, today, let's spend a little bit more time poking and pressing and rubbing and all these things that we might do to the sore bit to reduce your symptoms before we get into the exercise. And now we're starting to see this much more holistic, broader reaching, and a little bit more, an expanded scope of practice that still sits within the ethical scope of practice of each person, because we're just doing the things we're trained in, but maybe emphasizing other parts of that scope at times when needed. So I don't think anybody is a just anything. No one's just a massage therapist, just an exercise physiologist, just a chiropractor, just a whatever. You have a huge scope of practice. It's just about where do you put your attention? Where do you put your time? Where do you put your effort? And that can be different from patient to patient.
Yeah, that's right. And you don't have to be good at everything, but identifying different areas, and you get a lot of this just from saying, hey, tell me a story. Tell me more about that, asking more questions like that, as opposed to focusing in specifically on something. But that'll sort of give you an idea of, okay, it sounds like there's some life stress. It sounds like there could be some negative coping behaviors. It sounds like there could be, a number of other things going on. Hey, have you enjoy doing some exercise? I know a great exercise physiologist that I could refer you to. I know a great nutritionist or whatever that may be. So using that to almost triage people can be useful in a way as well, when we think about that multimodal care. But also, you might not be an expert in something. That doesn't mean that you can't give a little bit of a prompt. And just to give you an example of that, I was at the gym yesterday, and one of the personal trainers was having their client do some squats, and then the client laid on the floor, and she was just pressing on her sacrum. Probably not trained in manual therapy, and that's okay, because all as she was doing is pressing on a sore spot so that she could then do the exercise with less symptoms. Great. Modulating some pain to do the exercise. So that can go both ways. You can modulate someone's pain with manual therapy and then get them to just do some gentle movement. It doesn't need to be a robust exercise program, but starting to get them moving. Once they get beyond decreased levels of symptoms, and they're starting to move a little bit easier, hey, I think you're ready for the next step. I'm going to refer you on to someone with a little bit more expertise and knowledge in exercise. Does that sound okay for you? Make sense?
Makes perfect sense. It makes perfect sense. This is my point, Bose. Like, we've all got this a much broader scope than I think we realize, and you don't have to go and stick needles in somebody when you're not trained in it, or you don't have to go and picture yourself as a counselor and offering specific emotional support kind of advice. That's not what we're talking about. It's just thinking about the other little things that you naturally do in your consultation that you can maybe intentionally do to provide a bit more opportunity for improved symptoms or change in the scenario for the patient. So I hope this chat's been an empowering one for people who are listening, and maybe you've been a little disenchanted with manual therapy based on some previous conversations we've been having around the things that it can't do. It's not that it can't achieve results. It's just not getting there the same way that maybe we were taught 10 or 20 years ago, and probably not getting there the same way that we may have taught it got there 5 or 10 years or 15, 20 years ago, because the information changes all the time. But you spend almost all of your time with your head in research. Like, if anyone listens to you and go, well, oh God, there's all this stuff we don't know. Well, Bo, that's your whole life. That's your job, is to bring this information to ACE so that we can share it with the rest of the world. And so we hope we hope that this information is useful and empowering, and it's designed to be challenging, because if we're not being challenged in the way that we think and behave, then we very quickly become stale in what we do. And that's part of our responsibility too, is to continue to challenge you guys to be the best that we can be in clinic.
Yeah, that's right. And I think I've been through the same process. I've had a lot of beliefs that are outdated or that have now evolved. But that's what's so exciting about it, is that we are continuing to learn and progress and understand what we're doing a little bit more. So it's okay to be wrong. And change what we're doing, or update what we think we're doing, because we still don't really know, but our understanding of likely mechanisms are starting to improve. So I think that's super exciting, and things will continue to change.
Agreed. Should we leave it there?
Yep.
Let's leave it there. Thanks everyone for tuning in and listening once again. See you next time.
Cheers.